Hello, Doctor. Doctors, good evening. We haven't finished the cystic fibrosis microbiology guidelines, so today we're gonna have a look on it very quick. We don't want to spend longer time on that, just 2 pages. Okay, let's start. So as we mentioned so far in the previous videos, about the cystic fibrosis patients, it's crucial to keep the standard precautions and hand hygiene. The following precautions are required for patients infected with potentially transmissible pathogens. So this couple of advices you can tell the patient himself or herself or the parents, that do not share equipment between patients, nurse, children with CF in a cubicle, prevent contact between CF patients. It's a very important standard, and you have to follow in the ward if you have decided to admit the cystic fibrosis patient. Okay, so in here we have different categories of the treatment. If you have the patient newly diagnosed with cystic fibrosis, so you will have to start with him after discussion with the cystic fibrosis team, the prophylaxis with the flucloxacillin 125 milligram orally every 12 hours until age of 2 years. Okay, so this is the first step. If a newly diagnosed cystic fibrosis patient has chest infection requiring IV antibiotic, you will start the cefuroxime IV for 2 weeks. Subsequent treatment, and if you need to change the antibiotic, you have to discuss with the CF team first. So the antibiotic change will depend on the future culture and sensitivity of the sputum. So basically and initially, you will start after discussion with the CF team flucloxacillin orally 125 milligram every 12 hours until age of 2 years. And if it's newly diagnosed and he has chest infection, he is symptomatic and he needs IV antibiotics, so you will start cefuroxime IV for 2 weeks. Okay, so we have different pathogens in here. We have the Pseudomonas aeruginosa, which is the common pathogen in CF patients. So first isolation in sputum or cough swab, it depends whether the patient symptomatic or asymptomatic. If the patient asymptomatic with first isolation from the sputum or cough swab, so you will start CC. What does it mean, CC? That's to make it easier for you to memorize. CC means ciprofloxacin and cholestyramine sodium. So if was asymptomatic, he has not any symptoms, but you have got Pseudomonas in his sputum or cough swab. So you will start with him CC, ciprofloxacin, and cholestyramine sodium. Actually, I don't focus on the doses in the book. I can't myself memorize the doses. Anyway, you will revise your PNF book. If you are in your workplace, you never memorize any doses. It's basically illegal to memorize any doses because you cannot depend on your memory. So every time you will prescribe any medication to any patient, you have to go back to PNF and double check the doses, and you calculate it over and over and make sure it's the right dose. So anyway, in this book, they written according to the ages, ciprofloxacin aged 1 month to 18 years. That's 20 milligram per kg orally, 12 hourly for 6 weeks. And cholestyramine sodium nebulized for 3 months. Okay. And again, according to the age, less than 2 years, more than 2 years, you can have a look on that by yourself and double check the PNF book as well. So that's the asymptomatic CF patient. If symptomatic, he has symptoms together with isolation of the pathogen from his sputum, you will start with him CT. What's that CT? It's again mnemonic that to help you to memorize the okay, again, we have said that if the patient is symptomatic, you will start with him CT after discussion with the CF team, tubramycin and ceftazidime IV for 2 weeks, followed by nebulized cholestymitate sodium at doses listed above. Okay, if organism is not successfully eradicated after 2 months of treatment, consider 4 weeks course of nebulized tubramycin as directed by CFT. So just to summarize these important points, if again, if the patient was asymptomatic and he has the pathogen in his sputum, so we will start CC after discussion with CFT, which is ciprofloxacin for roughly 6 weeks, and cholestymitate sodium nebulized for 3 months. If the patient was symptomatic, we will start with him tubramycin and ceftazidime IV for 2 weeks, followed by nebulized cholestymitate sodium at doses as they mentioned. If there was any successful results with this regime, after 2 months of treatment, you will think about 4-week course of nebulized tubramycin. After discussion with the CF team, they will they have the upper hand in here, and you cannot do or prescribe any treatment for the CF patients without discussing with the CF team. Okay, chronic infection with the Pseudomonas aeruginosa. How we know that this patient has a chronic infection is really colonized with Pseudomonas. It's defined as if there was more than 50% of microbiology sample positive for Pseudomonas aeruginosa in previous 12 months, minimum of 4 sample patients with chronic Pseudomonas aeruginosa to receive a nebulized antibiotic prophylaxis. The choice of the medication, whether it's cholestymitate sodium or tubramycin or aztreonam, will be decided by CF team according to the clinical status and microbiology sensitivity. So everything you will mention in CF guideline, you have to mention CF team. It's very crucial to mention in your station. If you have a CF patient, don't forget the CF team. Okay, so that's the chronic infection with Pseudomonas. What's about the Burkholderia cepacia complex, BCC? If it was the first isolation, sputum or cough, of course you will report the new cases to the CF team immediately. Eradication to be attempted using a regime containing IV and nebulized antibiotic. The choice of agent depends on the sensitivity again. Chronic infection with BCC, it's the same. If there was more than 50% of microbiology sample positive for BCC in previous 12 months. Children who they have the chronic BCC infection to receive a nebulized antibiotic prophylaxis. The choice of agent tubramycin or all right, the CF patients who are colonized with the BCC, they will receive nebulized antibiotic prophylaxis. It's whether tubramycin or meropenem, again, will be decided with CF team. Children with transmissible strain of BCC need to be nursed in a cubicle on a separate ward from other CF patients. So these patients will be separated even from the other cystic fibrosis patients themselves. We have the MRSA as well, the patients who are colonized with the MRSA, methicillin-resistant Staphylococcus aureus. The first isolation, we have to report again to CFT immediately. We have if asymptomatic or symptomatic. If asymptomatic, attempt eradication using nebulized vancomycin for 5 days, followed by 2 or 3 oral antibiotic for 6 weeks. So first of all, nebulized vancomycin for 5 days, and then 2 or 3 oral antibiotics for 6 weeks. If symptomatic, eradication to also include 2 weeks IV antibiotic. The choice depends on the sensitivity as well, and you have to consult the CFT. Chronic infection with MRSA, defined is the same, more than 50% of microbiology positive for MRSA in previous 12 months. Use of nebulized or oral antibiotic prophylaxis to be discussed with the CF team. Okay. The next page is talking about the chickenpox and the CF patients. Varicella infection can have serious consequences in immunocompromised children. CF patients taking oral corticosteroids will be at high risk to catch infection. If no history of chickenpox and no antibiotics, no antibodies, they have to be vaccinated. They are talking in details in here about it. So let's see. Ask about exposure to a known case, being in the same room, in the same house, classroom or hall in school for 15 minutes or more. Face-to-face contact whilst having a conversation. If exposure significant, check notes to determine immune status. History of chickenpox or antibody status before corticosteroids is very important. If non-immune and taking a high dose of oral corticosteroids, that's prednisolone 1 milligram per kg per day for 1 month, or 2 milligram per kg per day for 1 week, and exposure occurred less than 96 hours earlier, request varicella zoster immunoglobulin. And again, they put the doses in here according to the ages. If non-immune and taking a modest dose of oral corticosteroids, or a higher dose, and the duration of exposure more than 96 hours since exposure. So in this case, you will give acyclovir prophylaxis 6 hourly. Again, they put the dose in here, 2 milligram per kg orally every 6 hours from 7 to 21 days after exposure. Okay, infected. So what does it mean infected? That's he already caught the chickenpox and he is symptomatic and he has a rash and fever and all the symptoms of chickenpox. So if chickenpox appears in a child not taking oral corticosteroid, give acyclovir 10 milligram per kg orally every 6 hours for 7 days. If IV, and you will give IV if the chickenpox is severe, and a course of oral antibiotic coamoxiclav. Okay, so in this case, you'll give antiviral and antibacterial at the same time to prevent the secondary bacterial infection. It's very important to do that. If taking steroids, discuss the varicella immunoglobulin with microbiology consultant. What about the influenza and pneumococcal vaccine? If it was a vaccine every October, that's every year in October, the start of the flu season. So every October, conjugate pneumococcal vaccine, Prevnar 13, usually prescribed by patients on GB, but obtainable from the pharmacy. Okay, so the flu vaccine and the pneumococcal vaccine, Prevnar 13, it's crucial for the CF patients. They have to take it. Portacath, use in children requiring frequent IV antibiotic. Manufacturer's instruction found in word. Observe sterile precautions whenever Portacath accessed only by trained nursing staff, which is the CF nurse. She is the only person who has the responsibility. She is in charge to insert the Portacath for new diagnosed patients, to clean it up and to change it, to replace it. She is the only person in charge to do that, and she will be trained beforehand of before for this purpose. Okay, routine flushing of Portacath, usually by nursing staff, every 4 weeks. Every 4 weeks, they have to flush the Portacath. Use a straight Portacath needle and formula heparinized sodium chloride, 100 unit per ml, with the drawing needle while injecting the last ml. So this is the microbiology guidelines for CF. That's to finish the CF guidelines completely. We have spoken about the DIOs first. So far, DIOs, the exacerbation, the admission, and today we have finished the last thing in the cystic fibrosis guidelines, which is the microbiology and the treatment of choice. So I wish doctors you enjoy this video and you like it. And please leave for me a comment down below the video. If you have any comments, if you have any piece of information you would like to share with me, I am very happy to read your comments. Thank you, and best of luck in your exams.